Hey guys, today we're going to do pain management in children. Hopefully you've had a chance to look over it. Let's see, let me fix this real quick. There we go. So since 1995, the American Pain Society has labeled pain as the fifth vital sign. So you guys know that whenever we are in clinical or anytime we're taking care of a patient, that we always assess their pain. Not only during vital sign, measurement, but all the time, really. But just be conscious that according to the literature, pain is defined as an unpleasant sensory and emotional experience that is associated with actual tissue damage or potential tissue damage. And in one article, it was written that pain is whatever the person says it is, existing whenever the person says it does. That is, pain is present when the person says that it is. And that reminds me of the FACES scale. It's not our job to assign a face score to a child. It is the child's job to point to the face that represents their pain. So do be aware of what is the difference in acute pain versus chronic pain. Your book is going to talk about that some, the difference in nociceptive pain and neuropathic pain. Just read over those sections. I want to talk about some misconceptions. The first one is that many people think that because the child is an infant, that their nervous system is immature. And since their nervous system is immature, they don't feel pain like, to the degree that we would. Their pain intensity is less. But by 30 weeks of gestation, so by the time the baby is 30 weeks, the pain pathways or synapses are developed. And infants may actually be more sensitive to pain. Let me put it like this. Their pain pathways have been proven to be in existence by 30 weeks gestation. The reason they would be more sensitive to pain than an older child or an adult, can you think of a reason? It has nothing to do with those pain pathways, the presence of them or the lack of, and everything to do with coping mechanisms. They can actually, especially preterm infants, be more sensitive to the pain because they have immature pain control mechanisms. They've never felt anything like it before, and they don't know how to cope with that. Misconception number 2 is that infants and children have no memory of pain. I worked in NICU for a while when I was a new nurse, and that was something that I always wondered about. With these babies that get these heel sticks every single day, or just all these things that they endured for months as soon as they were born, what kind of impact that might have had on them. Well, I think the way we might have made ourselves feel better is to think, well, they won't remember this. But actually, studies have shown that neonates who had numerous heel sticks with alcohol prep anticipated pain when smelling alcohol and had higher pain responses. They smelt that alcohol and they knew what was coming. They anticipated the pain, had anxiety. Whether they really understood their anxiety or not, they had intensified pain responses because of what happened in infancy. So that was very interesting and disturbing to me. Misconception number 3, children are not in pain if they can be distracted or if they are sleeping. Oh, this is a big one. And I still go round and round at times with people over this one. We understand, hopefully, by now, that children and adolescents use distraction to cope with their pain. Being in a painful state is exhausting to a child, and eventually they fall asleep. But if you say, well, I can't treat their pain because they're asleep, then when they wake up, you're even that much further behind um, in controlling their pain. So children use distraction to cope. They become exhausted from the pain and eventually go to sleep. And then finally, misconception number 4. Children are at increased risk for becoming addicted to pain medication. I can't blame families for worrying about this with all the attention that opioids and um, drugs get in the media and experiences that families may have had with a loved one or even themselves with addiction. So that's a valid concern. So what I need you to do is educate the families that based on the evidence, there is a less than 1% chance that treating their child's acute pain will lead to addiction later in life. It is extremely rare. So, you'll probably figure out by the end of this lesson that this is a topic that I'm passionate about. And I have a lot, there's so much literature about it. It's crazy. Talk about disturbing. In this day and age, there is so much literature out there about pediatric pain management and nursing care and how we're just not we're not doing what we should do. And why is that? It's just it's mind-blowing, but in another hand, I understand because people are afraid. It's ignorance. It not in and I'm not being ugly when I say ignorance. I'm saying it's lack of education in some instances, it's peer pressure in other instances, and then we really don't know what it is. That's what some of the articles are about. So instead of giving you a million articles, I had just posted the key points from the articles throughout my lessons. So Twycross, she's have a few of her articles. She says, although in all probability, nurses' knowledge about opioids has improved over time, some still do not maximize analgesics for pediatric patients post-op, which may be partly due to continued misconceptions. So, this is kind of wrapping up those 4 misconceptions that I shared with you. It is a problem. This is another way to look at it, is that there is a problem with knowledge translation. If we know, I'm telling you right now what the evidence says, you read the literature, you read your textbook, you know what to do. Why is it that when we are out there in practice, we don't do it? So that is called the problem with knowledge translation. So here we have some more truth according to the literature for you to think about. This is from an article that I just felt the nurse's pain. She was saying, I just don't understand. I've worked with these nurses. They're good people, but yet I'm seeing, I don't like what I'm seeing. Caring nurses delivering care that was not always explainable, and children suffering pain despite orders for analgesic medications. Another article, some professionals hold outdated beliefs. Can you believe that? Nurses believe some pain is to be expected. I mean, I'm guilty of even having said that to children, and I don't know that that's really wrong. I don't want them to think that they're not going to hurt at all post-op, but I guess there's a fine line with um, using that as an excuse not to treat their pain. Nurses believed 20% or more children over-reported their pain. So they don't really believe the scale results. Non-pharmacologic interventions were seen as the parent's job. Non-pharmacologic interventions can be very helpful, very helpful. Just repositioning a patient could solve the problem. But we have to take the initiative and not just jump on the easiest thing we can do, which is go give them some medicine. Action was not always taken when the pain score was greater than or equal to 5. In any of your documentation, if you were to tell me that their pain score was 5 or greater, I would expect you to intervene in some way and not just make that blanket statement and walk away. Nurses reported struggling to reconcile children's behavior with reported pain scores if they were not behaving in a way that made it clear they were in pain. So that's the child that's playing video games on a cell phone or whatever he's playing on, so he must not be hurting. But obviously we know he's using distraction to cope. Even when nurses had a good level of knowledge, this may not be reflected in their pain management practices. And this is a good one here. Nurses are morally and spiritually responsible for easing the patient's pain. That's our job. From a child's perspective, it has been said they would like nurses to administer analgesics as soon as they ask for them and provide meaningful things to do to distract them from their pain. I've had an experience with my own teenager where he was administered an IV narcotic, and when the pain got bad again, he didn't like the way the medicine made him feel, and he wanted me, probably one of the few times, he wanted me to sit beside him and just talk to him because it distracted him. He said, if you quit talking to me, then I just focus on the pain and I can't handle it. So keep talking, talk to me. And that was very interesting, and it reminded me of what I had read. So what kinds of things influence a child's response to pain? What do you think? What about past memories, past experiences that they've had? You know, if they've fallen out of a tree and broken their leg, then the pain of slicing their thumb open while they were, you know, helping mom chop vegetables may not be as bad because they know what it's like to have a femur fracture. But the child who has never had pain and doesn't like that severe pain would react differently. So memories is one thing. Another thing would be the child's temperament. Are they naturally a dramatic child, a stoic child? You know, what is their inborn temperament? Ability to control the situation. This is a big one. When you let anxiety rule and you are unable to stop the pain from coming and you know it's coming, then that will exacerbate your experience. And coping mechanisms is another one. What have they ever been? Have they ever been in situations where they have had an opportunity to explore coping mechanisms, or have they ever had anyone teach them how to cope? The different options, you know, counting backwards, thinking about your favorite place where you like to play, and how it's spent. You know, there's lots of different things that we can read about, and we talk about a little bit later. And then just their emotions at that time, whether they're very afraid, very anxious, if for whatever reason. So memories, temperament, ability to control the situation, coping mechanisms, and emotions all can influence a child's response to pain. So if a child is in pain, what are some ways that they might express that pain? So do you think everyone cries? Mm, no, depends on the age, right? All the different age ranges. Some children may express their pain through anger or acting out. Others through anxiety type symptoms. What if it's a baby? Feeding problems, and sleep trouble. We can see feeding problems and sleep trouble in infants who cannot tell us that they hurt or where they hurt. List some reasons children may not complain of pain. Well, I think the first thing that comes to mind is that they're afraid that they're going to get a shot. They're afraid the treatment will hurt more than the pain they're experiencing now. But there are three other things I want to point out. One is limited vocabulary / experiences. So they may not complain of pain because they don't know what words to use. If they've never experienced a throbbing pain, and they're of an age where they don't have the word throbbing in their vocabulary, you know, that's a real issue. Another reason could be that they're trying to be brave. You know, they don't want to worry their parents or upset their parents. And I've seen that, and especially the school age child. Um, they don't like to see their dad cry or their mom cry. And so they will not complain because they don't want to upset the family. And then this one was one I had not really thought about as much. Children of particular ages assume that we know. They assume the nurse knows that they are in pain. They don't think they have to tell you. They think you know. The nurse is preparing a toddler for the repair of an eyebrow laceration. The girl is most likely to demonstrate which of the following responses in anticipation of the procedure. So we're talking about a toddler having to get a cut sewed up on her face. How is she going to react in anticipation? The toddler will remain outwardly calm and ask lots of questions. Scream and cling tightly to her parent. Stare out the window while clenching her hands, or attempt to postpone the procedure by asking to go potty. So if you miss this question on a test, it will be because you chose D. And the correct answer is B. Yeah, but I remember my kids doing that. You know, they would try to postpone the shot or whatever it was because they needed a drink of water, or they needed to go to the bathroom, or, you know, any excuse. And that's true for preschoolers, not toddlers. So toddler is our key word here. They will scream and cling tightly to their parent. Some questions to ask older children. Things like, what kinds of things have helped your pain when you've had pain in the past? What kinds of things have hurt you before? And like, what made it feel better? What kinds of things worked for you before? What do you tell your mom or dad when you are hurting? And if you tell them you're hurting, what do they do? What would you like me to do for your pain? What would you like me to do? And then, where do you hurt? what does it feel like? And this is my favorite. What do you think is the cause of your pain? Pain assessment scales. We've got nonverbal and verbal. So I'm not going to go over every scale that's in the book, and I'm not going to test you on any scale that we're not going to talk about on this presentation, okay? So as far as our nonverbal scales, I've listed NIPS and FLAC. NIPS is more appropriate, well, it's appropriate for any neonatal patient, but I mean, maybe they use it more in the NICU because it reminds me of what we had in NI. But I just am not in the habit of using that, but it would be appropriate for a neonate. Now, FLAC, you know that I do use anytime we have a nonverbal patient. And then there's one more that is called the location scale, where they have a drawing of their body and they can point. And that would be appropriate for like 3 years and older. And they're given an outline, the front and the back of the body, and they can mark with a marker or a color where they're hurting. So let's look at that NIPS scale. Let's see. So here's a picture of it. It's similar to FLAC, but it includes heart rate and pulse ox. Neonates and premature babies, when they're sick, when they're hurting, when they're cold, if anything's wrong, not as it should be, they tend to have apnea and bradycardia, and that's why we've included our heart rate and O2 sat on there. And then here we have our FLAC scale, which is one of my personal favorites. And I like to think, after I assign a FLAC score to a child, I think in my mind, now, if they were able to talk and were able to point to what face they were on the FACES scale, it's neat to me to see that their score would match up with the appropriate face on the FACES scale. So, even when you're asleep, you can grimace, you can be restless, shift back and forth. You might moan in your sleep, but you can be reassured. It's okay, mommy's here. It's okay, go back to sleep. So you can use FLAC when your patient's asleep. Don't ever say they're not in pain because they're sleeping, or you can't assess pain or reassess pain because they're asleep. So now we're looking at the self-report scales, or the verbal. This would be where you show the Wong-Baker Faces scale to the child, and they point to the face that represents their pain. You should not use this tool as a comparison to the face that you see when you look at the child. Just because a kid's smiling or playful, if they point to a 6, then that's what they are. And then you know about your numeric pain. So just remember that the child is the one that has to actually point to the face. So now let's look at some different types of indicators of pain. We have behavioral indicators and physiologic indicators. So first off, the physiologic indicators: fast heart rate, fast breathing, high blood pressure, sweating, pallor, maybe even, well, that's what clammy would be, diaphoresis, obviously, and dilated pupils. So tachycardia, tachypnea, diaphoresis, pallor, those are physiologic. Behavioral indicators would be things like grimacing, whining, their eyes are big, they're hyper alert, very restless, and they can even become agitated or combative. But I want to point out that all of these things, the tachycardia, tachypnea, hypertension, those physiologic indicators make up something called the stress response, the complex stress response. And I want to explain to you that after a few minutes of the body being in this state, having this stress response, the body will adapt. The vital signs will return to normal. The sweating will go away. Their color will come back, but the pain hasn't gone away. This is our complex stress response. So this matters because you can't walk in the room and say, well, you know, he's not really hurting because his heart rate's 62, or his blood pressure's fine, or this or that. Please be educated on the complex stress response and know that the body can adapt to pain and not show physiologic indicators. Physiologic indicators. This is from an article in 2007. Physiologic indicators are now considered an unreliable measure of a child's pain, and this perhaps explains why their use is not explored in studies from 2000 onwards. Are you hearing me? From 20 years ago, the literature says we're not paying attention to their heart rate or their respiratory rate when we're trying to assess if they're in pain or not, because they're unreliable. They're not valid. So please, there's no need to get into an argument with anyone about it. It's in the literature that those indicators cannot be depended upon. The errors that drew more attention were related to vital signs are always reliable indicators of pain intensity. That was out of the nurses that they surveyed, almost 35% believed that vital signs were always reliable indicators of pain. 42% believed patients usually develop respiratory depression when given pain medications. 42% said if I give them morphine, they're going to have respiratory depression. I'm sorry, but have any of you guys that have had a patient on a fentanyl PCA pump, had a patient with an issue of respiratory depression yet? It's very, anyway, I'm not going to go off on that. But, and then 60% of the nurses believe that patients that can be distracted from the pain do not experience severe pain. And that's huge. That's huge. That's from developmental psychology. You know, that prereq that you took online and rushed through, 60% of nurses forget about how children cope with pain. So now I want to talk about some consequences of pain. When we look at our respiratory system, if you leave a child with untreated pain, it makes sense that they will not take deep breaths and they will not want to cough. And that shallow breathing and cough suppression could lead to things like pneumonia. Pain causes an increase in myocardial oxygen consumption. So it's making the heart work harder. Uncontrolled pain actually causes suppression of our immune system. And a major post-op problem is the return of bowel function or potential development of a stress ulcer. And if you add uncontrolled pain on top of the fact that they're post-op, it exacerbates this, and we can have even a further delay in the return of function and increased risk for that ulcer. And then just as far as healing, if you have a poor appetite, then that leads to reason your nutrition will be poor, And that in itself leads to decreased energy and delayed healing. So when I have a parent that is afraid to allow us to administer pain medications, this is the evidence that I can use to encourage the parent. Plus, that less than 1% actually get addicted, or in adulthood, as a result of this instance of pain administration. I use these things and explain to them that if we allow the pain to not be treated, then your child could end up in the ICU on a ventilator because they hurt too bad to take deep breaths or to get up and walk, or whatever it may be. New evidence suggests that mismanagement of post-op pain may lead to chronic pain. Researchers determined that if acute post-op pain is not well managed, a patient is at risk of forming a pain memory, along with experiencing chronic pain, both of which have long-term effects, physical, psychological, social, and developmental consequences. And that was in 2017. So that's just another problem of that can result from poorly managed pain. So tomorrow we're going to pick up with our pain therapy and go over some pharmacologic and non-pharmacologic therapies, and I will see you then.